Good afternoon, everybody. Can you all hear me? I'll give it a start of this third webinar, and hopefully more people will join later. For who does not know me, my name is Marianna Biggi. I am Italian. I have started my career at the University of Milan as a PhD student and then moved to the UK, first at the Animal Health Trust, where I spent about 7 years, first doing research and then as a resident doing my residency in diagnostic imaging, and I became a diplomat of the European College of Diagnostic Imaging in 2015. I then worked as a lecturer at the Royal Veterinary College, and now I'm head of VetCT Equine since 2017. My special interest is in cross-sectional imaging and specific MRI of sport horses. So today we talk about radiology, and we'll talk about Hock and Stifle, and hopefully I will give you tips that you can use in the future for image acquisition and interpretation. You can ask question during the talk in the chat, and then I will try to address them at the end. You can also ask directly a question at the end if you want. We can unmute you. What I want to talk to you about in this talk is how to critically evaluate the radiographic quality. I strongly believe that having good images makes your interpretation much easier than have a poorly positioned image. So if you start with good image, you're halfway there already. Then we'll look at some specific radiographic abnormalities. I have no time, of course, to present everything you could find in these regions, but we go through quite a lot of findings, and then we'll see how these may correlate with the clinical examination and their significance, and also with advanced imaging modality in some cases. So first of all, we need to think about why we are taking radiographs of the tarsus, and well, we can do it as a part of a pre-purchase exam. That's very common, or perhaps we have seen some swelling in our clinical examination, or the horse had a known trauma or wound to the tarsal region, or most likely we can have lameness. Sometimes radiographs of the tarsus and also the stivals are taken sort of as a screening without necessarily block the horse. Not that I'm particularly a fan of that, because then you don't know if the lesion is significant or not, because you don't know where the lameness is localized to. So better to do some diagnostic analgesia and see where the lameness is localized before taking radiographs. Just a little note, when you do the analgesia with the deep brush of the lateral plantar nerve, we know that the accuracy of this block is not 100%. We are supposed to block the origin of the suspensor ligament, so the proximal tarsal region, but actually there is diffusion of the anesthetic proximally, which can interfere also with the tarsal sheath, and anesthetic level of mepivacaine have been found in a quarter of the horses in the tarsal metatarsal joints, and therefore radiographs of the tarsus in horses that block the deep branch of the lateral plantar nerve is something that we should do. Also remember that the anesthetic as the contrast diffuse distally, and therefore this block has the potential to affect pain originating from the metacarpophalangeal region. Metatarsophalangeal region, and therefore we should first exclude distal limb pain. Usually before taking radiographs of the tarsal of any region, I'm I try to spend a little bit of time to position the horse properly, and that is a horse needs to be square with the weight evenly distributed on all limbs. But if we think about the tarsus specifically, I think it's quite useful to have the metatarsal bone perpendicular to the floor. So if we look at this tarsus, to me, the metatarsal bone is tipping forward a little bit. And if we just push the limb backwards slightly, we can have a better position. And once the horse is straight in this direction and also seen from the plantar aspect, then we can acquire all the four views without moving the horse and very quickly, and be sure we'll be able to go through the joint spaces nicely. Standard projection with the tarsus, well, I normally start with lateral medial view, which I normally acquired 5 degrees angle down to go nicely through the joint spaces of the distal tarsus, and I usually center about this level, so about the center tarsal bone. This is a radiograph that I will consider suboptimal, and that's because I can't really evaluate the joint space nicely, and therefore if I have to interpret such a remodeling of the dorsal aspect of the central or third tarsal bone, it will be difficult. So I will repeat this radiograph. A dorsal plantar view is also one of the standard views, and this is how I would like it to have, with all the nice joint space is visible. Sometimes this is not very always easy to obtain. Sometimes even if you position the horse well, the lateral aspect of the joints, it's not visible. Like in this case, we can see that both the distal and the proximal intertarsal joints are not visible. So I'm pretty sure this is positional. However, I would like to repeat this view to confirm this. And in this case, angle the beam 5 degrees down, or perhaps center higher, so at the level of the talus may solve the problem. Some people will acquire a slightly oblique view, a dorsal 15 degrees oblique view, DP, as a standard view, and that is to highlight changes of the medial malleolus of the tibia, and that really depends which sort of horses you have. If you are x-raying a young horse or a horse which you suspect osteochondrosis, then perhaps this view is more important than the standard DP. Not very much else to add about the oblique views. As long as you go through the joint spaces nicely, I'm happy with those. Just a quick note about additional views which you can acquire of the tarsus. The skyline views is very useful to evaluate the tubercle canae. The important thing is to hold the leg parallel to the floor, and then angle the beam in proximal distal direction about 80-85 degrees, but as steep as you can, basically. And I'm happy of the views when I can actually see the tarsal metatarsal joint. And that's useful to evaluate the sustentaculum thalli and the tubercle canae, and this is the area of insertion of the superficial digital flexor tendon. Flex lateral medial view is not a view that I acquire very often, but it's useful if you suspect lesion in the caudal distal aspect of the tibia or in the plantar aspect of the trochlear ridges of the talus. We have some normal variation in the tarsus, which we should be aware of when we look at these images. Flattening of the medial trochlear ridge of the talus is seen often as an incidental findings, and if there is no sclerosis adjacent to that flattening, that's incidental. This picture is taken from Butler and shows all the variation in shape of the distal end of the lateral trochlear ridge, and we can see that sometimes it's also fragmented. And this is also incidental and should not be confused with osteochondrosis. Another incidental finding, which is a little bit less common, is the fragmentation of the proximal tubercle of the talus. This has a prevalence of about 0.6%, so it's really not very common, but it's much more common in warm blood horses compared to any other breed. So the likelihood of you seeing this really depends on which type of horses you see. And I'm not sure if that, also there are some bloodlines that have higher prevalence of this finding, because I very rarely see this in horses coming from the US or Australia, for example, but we do see them in Europe. This is not associated with lameness. You can see the fragment nicely in the lateral medial view and in the DMPLO. And if you have a skyline, that's also useful, but not necessary. And the reason why is the fragments usually originate from the plantar aspect of the tubercle. This is the medial tubercle of the talus, which has got a groove where the medial digital extensor tendon runs through, and that's the location of the fragment. This is also the area of attachment of the medial calcaneal ligament. And this is one of the an example of a fragment that I found in one of the hocks that I've MRI'd as part of projects of normal horses, and you can see the fragment, the thickening of the cortex of the tubercle, but there was no alteration of signal intensity in stir, confirming that this was most likely not clinical significant. I'm not talking about osteoarthritis, just a few words. We all know the radiographic findings associated with osteoarthritis, joint space narrowing, ossified, subchondral bone thickening, and lysis. And no one will have any doubt in diagnosing osteoarthritis in this case of this in the dorsal joint. We can see lysis of the subchondral bone, both of the central and tarsal bone. Occasionally, we see osteoarthritis of the tarsal metatarsal joint, which in isolation is not very common, but this is a real severe case of osteoarthritis of the tarsal metatarsal joint. What we need to remember when we look at radiographic findings of osteoarthritis is that there's not necessarily an association between the severity of the radiographic findings and the duration of lameness or the degree of lameness. And we do see horses that are that have severe radiographic changes, and actually they're only mildly lame. And on the other hand, we see horses that are very lame, but they have only very subtle changes. And at that point, we need to ask ourselves, well, how sure are we that the lameness is actually localized to the tarsus, in the sense that it may have suspensor ligament pathology, which can cause this degree of lameness. But if we are sure that the lameness is localized to the tarsal metatarsal joint, then perhaps we should think about other image modalities to see if which sort of lesion we can identify, because we know that radiography has a limitation in identifying lesion in other locations, so why not in the tarsus? And this case was taken from a paper over years ago, and we actually tried to answer this question. We had 3 horses that were moderate to severely lame, with lameness localized to the tarsal metatarsal joint, but not very much to see radiologically. And on MRI, they all had subchondral bone lesion, which increased signal and stir, and one of them also had an incomplete fracture. A region that is potentially overlooked is the region of the central distal joint interosseous ligament. The interosseous ligaments are located between the central and third tarsal bone, and then between the talus and the central tarsal bone, and at the level of the TMT. And we can see these areas as loosened areas surrounded by a nice thin sclerotic rim. And this interosseous fossa can be seen in all views, but I really like to evaluate them on the dorsolateral plantar medial oblique view, especially the central distal. And if we look at these two horses that are abnormal, in this case, we can see that the area is actually changed in shape. So we lost the oval shape of the fossa, and there is increased opacity within it, and there is certainly thickening and irregularity of the cortex that surrounds the interosseous ligament fossa. We may also think that the joint space dorsal to the interosseous ligament is a little bit thinned, but not very much else. There is no periatic osteophyte. And this is a quite profound case of sclerosis of the central distal interosseous ligament region, where the fossa cannot be seen at all. And again, you can probably imagine narrowing of the joint space just plantar to this interosseous ligament. So these changes can be seen in isolation, but more often are associated with osteoarthritis of the distal intertarsal joint, and is more commonly seen in lame horses. But as per other sign of osteoarthritis in the tarsus, they can also be seen in non-lame horses, or at least not lame at the time we see them. This is another example of changes of the interosseous ligament, which we can see in the dorsolateral plantar medial oblique view, and perhaps also in the dorsal plantar view. This horse also underwent CT, and I think it's quite interesting to see the extent of the lesion that we see on CT compared to radiographs, just to give an idea how much we underestimate changes radiologically. We can see here the changes in interosseous ligament, but there are marked changes of the joint space plantar to the interosseous ligament, and there were also quite substantial abnormalities at the joint between the central and central and fourth tarsal bone. And when I saw that this case, at the time of interpretation, I found it quite interesting that all the lesions were plantar, located within the joint. And when we normally think about osteoarthritis of the tarsal, we look dorsal, and our eyes are trained to look at the dorsal aspect of the joint, but actually we should look also plantarly for changes. Sclerosis of the tarsal bone, specifically sclerosis of the central tarsal bone. I know that is listed as a sign of osteoarthritis, but it might experience that is not necessarily associated with osteoarthritis. It's also radiological finding that is very easy to miss, and that's because you really need to compare the opacity of the bone with the opacity of the other bones. First of all, you need to decide that your radiography is well exposed, and therefore the increased opacity is not artifactual, and then compare it to the other bones. So in a normal bone, like on this view, you can see the normal cortex and the nice trabecular pattern of the spongiosa in both central and third tarsal bone. While in this case, there is diffuse, severe increased opacity in the central tarsal bone compared to the normal third tarsal bone. And it's not a very common finding, but when I've seen this, it was either associated with subchondral bone cyst, like in this case. If you have spotted a little cyst, there is a little cyst here, which is then there. Or I've seen this in association with fracture. And we'll talk a little bit about fracture later. In this particular case, the osteocyst-like lesion and the sclerosis of the bones were considered the cause of the horse lameness. However, when we think about osteocyst-like lesion in the distal tarsal bone, small tarsal bone, these are not always clinical significance. And this is an example where you can see this well-defined round lucency in the dorsal medial aspect of the central tarsal bone, and this is not surrounded by sclerosis. And this was a pre-purchase exam. The horse had identical changes in the other limb, and as far as I know, it went on and competed fine. Different story is the cyst in the distal tibia, which are actually usually clinical significant, and they cause moderate to severe lameness, which can be intermittent in nature. Cyst in the distal tibia can be easy to identify, like this one. Sometimes a little bit more subtle, like this particular case. Both these horses had intense radiopharmaceutical uptake associated with this lesion, which helped the identification. And both those horses were negative to distal limb blocks and block to tibial and fibular analgesia. Fracture of the tarsal bones. If we think about fracture of the third tarsal bone, this is a pathology of racehorses. They have a specific location. Their fracture are located in the occur always in the dorsal media to plantar lateral direction, and that's just because that is the area of major stress, and they're believed to be stress-related bone injury. They are responsible for lameness in the majority of the cases. However, this particular horse, which had this sort of chronic-looking fracture, this was silent fracture. The horse was racing okay, obviously monitored, but was racing okay. Some fracture of the third tarsal bone are identified in wheeling and yearling at pre-serrage grafts without clinical signs. They're also in the same direction, so you can see them in the DMPLO view, and these usually heals fine, and the horses go on racing with no problem. There was some talking about possible predisposition for this third tarsal bone fracture, and it was thought that wedging of the bone might predispose to this fracture, but actually this has never been proved. Fracture of the central tarsal bone, they are much rarer in racehorses, and they usually occur in a dorsal plane, so you can see them in the lateral medial view. However, as I was telling you before, fracture of the central tarsal bone can also be seen in warm blood horses. And and there are two case reports, one from California and one from Zurich, that describes these fracture in a small group of non-racehorses. And this is from the Zurich study, where they also CT'd the horses, and you can see the direction of all their fractures, which were in dorsal medial to plantar lateral. So you really need that specific view to highlight the fracture. All horses had sclerosis associated with part of the fracture, and in the California horses, they all had acute onset of non-weight bearing lameness. That's not necessarily my clinical experience, but that's not because that is not true. Is that because we might miss part of the history when we get the horse referred to the hospital. So you might not know that he had an acute onset of severe lameness 2-3 months ago, which is not reported because it's not connected to the lameness that the horse is referring for now. This is a case that at the time was quite challenging. This horse it was an 11 years old Irish sport horse, which used for pleasure riding. This did have an acute onset of severe lameness, but by the time the referring vet went to see the horse, he was only mildly lame, and he blocked completely to the deep branch of the lateral plantar nerve. So that the horse was ultrasound and radiographs were obtained, and nothing was abnormal was seen at the time, and the horse was referred in for MRI. These are the radiographs I have acquired after the MRI. And I think you can see, especially in the DP view, that this central tarsal bone is quite sclerotic if you compare it to the third tarsal bone. And I was lucky enough to go straight through this loosened line in the central tarsal bone in this particular view. But if you go, if your angle of obliquity is not quite the same as the fracture, you can easily miss. But for me, what made me think about fracture is the sclerosis of the central tarsal bone. Obviously, I had also seen the MRI before taking those radiographs, which helped. This is the fracture line, and we can see the sclerosis surrounding it, confirming that this is stress-related bone injury. And this also has a bone edema type signal in the plantar aspect of the fracture site, which may be the reason why it was acutely low. This is another case which actually was referred as had a moderate lameness and was referred for full body bone scan, and we could see this intense, well, moderate to intense radiopharmaceutical uptake in the plantar aspect of the central tarsal bone, plantar medial aspect, which is not necessarily the area we're looking at for osteoarthritis. So we were looking for something else. And when we took the initial radiographs, again, we can see sclerosis of the central tarsal bone. Maybe you can imagine something is going on here, and with a little bit of obliquities of the views, we then managed to see the fracture. So it's a rare occurrence, but I don't think it's quite as rare as is depicted in those case reports. Other more common fracture in the tarsus, we have lateral malleolar fracture. That's very easy to identify radiologically. I think I have very much to add about it, other than we need to always ultrasound the collateral ligaments, because the short collateral ligament is always either partial or completely ruptured, and sometimes there is also abnormalities of the long collateral ligament. So this is the same horse. You can see in the ultrasound the fracture, the fragment, and the disruption of the origin of the short collateral ligament. Soft tissue injuries in the tarsal region. So we can look at radiographs and also look at the area of attachment of bone and ligaments for enthesiopathy. I would recommend you to download this paper. It's recent. It's got lots of nice colours, which highlights all the areas of insertion, all the ligaments and the tendons. And since these are not necessarily very common finds, it's quite nice to have a reference to go to when you do find remodeling that may be related to ligament attachment. The other thing we should look at radiologically is the presence of soft tissue swelling and the location. And you're going to probably tell me, well, look, I look at the horse and I can easily see where the swelling is. But sometimes the swelling might not be obviously palpated. Maybe the horse is very hairy, it's got thick skin, maybe you missed it, or maybe you haven't seen the horse at all, like me, and therefore it's very important to look at the soft tissues, because that might highlight area of pathology. This horse was 14 years old, warm blood gelding, which had acute onset of moderate left hind lameness. And the only thing I knew it was they had very positive left hind upper limb flexion, and the horse was not blocked as far as I know. Radiologically, well, there is this spur, it's quite pointy spur at the dorsal proximal aspect of the third metatarsal bone, which can be, may or may not be clinically significant. I mean, with this degree of lameness, I'm not particularly excited about this, this spur. unless you would do some more blocking. But what catches my eyes in this case is this swelling on the plantar aspect of the tarsus, which you can see on the medial aspect. Therefore, it belongs to the tarsal sheath, and that to me can't be incidental. So I'm really suspicious of some tarsal sheath pathology. So in the real world, then you will get on to do ultrasound of the tarsal sheath to evaluate the lateral extensor tendon. This horse may have had ultrasound, I don't know, but it certainly had CT, and CT has confirmed the effusion of the tarsal sheath. I think the tarsal sheath wall is also quite thickened, and it had severe changes of the lateral digital extensor tendon. This horse had no history of a wound, but based on the degree of changes that I can see on CT, I think the septic process could also be considered as a differential. And sometimes we see signs of chronic tenosynovitis. This is also not a very common finding, but we do see it, remodeling of the subsyntacral talo, like in this case. And it's nicely highlighted in the skyline view. And that's the reason for these bony changes, because this is the area of attachment of the retinaculums, and therefore when you have chronic effusion, you have remodeling at the attachment at the medial aspect of the subsyntacral talo. And this is the ultrasound that pertained to this horse, and confirming the effusion of the tarsal sheath. And if we look at the comparison of the right, which was the abnormal one, and the left, which is the normal one, we can see the difference in size of the ligament of the tendon and the hypoechoic lesion in the tendon. We can use radiology to look at remodeling or sclerosis at the origin of the suspensory ligament, and these are various degrees of changes. What I do recommend is to, if you look at this area, I think it's very important to look at the straight DP, because it can be quite misleading if your DP is it's oblique in one way or the other, and you might overinterpret this region. The other thing to consider, that even if the radiographs are normal, that doesn't mean the horse does not have profound enthesiopathy, which can be detected in other modalities, such as MRI, for example. Ligament enthesiopathy is a rare occurrence. This is the only case I found of mine that had enthesiopathy at insertion of the short lateral collateral ligament. The clinical significance of these findings on radiology alone is very difficult to determine, because these changes have occurred long time before we see the horse, and therefore we need to check ultrasonographically if the collateral ligament is still abnormal or not before judging the clinical significance of these findings. This is enthesiopathy of the origin of the plantar tarsal ligament, and this is something I've seen very recently. I've just seen 2 cases last month of the same enthesiopathy of the distal attachment of the plantar tarsal ligament. Both cases had very chronic and smooth looking remodeling at the level of the 40 metatarsal bone, with no evidence of swelling. And in both cases, I thought that, at least from radiographically, they were probably incidental at that time. Obviously, I always recommend ultrasound to confirm this hypothesis. Just a few words about trauma to the tarsus. It's very useful to take radiographs in horses with wounds in the plantar aspect of the tarsus, to highlight changes such as periosteal reaction and sequestrum, like in this case. It's also quite useful to do contrast studies of the gastrocnemius bursa to confirm, for example, in this case, the communication of the wound with the gastrocnemius bursa, while in this case, there was no communication between the two. This is a horse I was very surprised by when I saw it. This is a yearling. It had a trauma, run into a fence. If I remember correctly, it was stuck into a fence, and then it was lame. And when I x-rayed the first time, it was absolutely normal. And then 4 days later, it came back and they said that it has double local swelling. Can you re-x-ray and look at him again? And these were the radiographs. And I was very surprised to see the severity of the changes at the level of the tubercle canal, which developed in 4 days. It was also marked a fusion of the tarsal sheath, and when ultrasounded, there was it was confirmed the effusion lesion in the lateral extensor tendon, and also there was hemorrhage within the tarsal sheath. I was quite happy to say that perhaps this was septic in nature because of the how fast it progressed, but actually it was not. And this was confirmed post-mortem. The horse had necrosis of the bone dislocation, and it was non-septic. As you may see, this did not have a very good prognosis. So I have concluded with the TARSUS, and the stifle is much shorter, but we'll go through a few changes in the stifle. I hope that will keep to the time. The indication for radiography of the stifle are exactly the same as the TARSUS. The only note I want to make is that if you do intra-articular analgesia of the stifle, you should be aware that this can affect foot lameness, and it's been proved that foot lameness can be alleviated by 50% in approximately a third of horses that have intra-articular analgesia of the stifle done after 30 minutes. So again, we should always exclude lameness in the distal aspect of the limb before jumping on proximal aspects of the limb like the stifle. Standard projections, lateral medial view or flexor lateral medial view. I think you can take either of those as standard. Flexor lateral medial view requires an additional person to hold the limb, so it's probably not the easiest one to obtain in the field, but can give additional information about the proximal aspect of the trochlear ridges of the femur, and also helps in evaluating the cranial aspect of the tibial eminence. We should be aware of the variation of the stifle in skeletally immature horses, and especially if we look at very young foals, the fact that the trochlear ridges are normally very irregular, and this represents quite a challenge when the horse actually has a clinical sign of septic arthritis and you're trying to decide if the bone changes are normal or reflect osteomyelitis. And in those cases, I think it's important to look at the chondral bone. Is that thickened? Is there sclerosis? Or is only just irregular on the surface? And that might give ideas. In addition, you can recheck radiographically to see for progression. Caudal cranial view, it's a very important view to obtain, but can be a challenging view to obtain, especially if you have a portable X-ray machine. And that's because of the thickness of the soft tissue you need to go through to actually X-ray the stifle. You often end up with underexposed radiographs, like in this case. to improve image quality in this case, if you can't increase your exposure, then it's better to get closer to the horse and collimate. The more, if you collimate tightly around the stifle, then you reduce the scatter radiations and you will improve your image quality. The other thing that sometimes happens when acquired a caudal cranial view is that you don't see nicely the joint space. So normally you acquire the cranial caudal view with 15 degrees angle, proximal distal angle. And it does happen that you might have forgotten to do that, and that's why the joint space does not appear visible, like in this case. But often is again due to position of the limb. So if the limb is too far extended backwards, it's very, very difficult to go through the joint space. So look at the horse and try and position square to get better images. Oblique views will always obtain the caudal-lateral to cranio-medial oblique as standard. The other oblique view, the caudal-medial to craniolateral view, I had obtained it routinely for a period of time, but I'm not sure it adds very much to it, to the study, other than in specific cases. I've also tried to acquire it both from caudal-medial to craniolateral and from craniolateral to caudal-medial. I have to say it's not easy either way, but you can obtain both directions. It's just very difficult to get the patella included in the picture. I would acquire scarring of the patella if you have indication of patella fracture or luxation, and that is it's not a difficult view to obtain if you have the correct positioning of the limb. So the person who holds the horse needs to hold the tibia as much as possible parallel to the floor. And it's also very useful if the leg gets pulled across over the contralateral limb, so then the stifle points outwards and then the patella is not superimposed over the belly of the horse. Also, the mistake that sometimes is done is trying to acquire the view with a quite steep angle. And if you do use a steep angle, actually the only thing you see is the tip of the patella, while you want to see also the articular surface. And therefore, using a 45 degrees angle as suggested in Butler is the best angle to evaluate the entire patella. Some stifle pathology. So here we have a 17-year-old cob, which had chronic left hind lameness, and this horse responds well after intra-articular analgesia of all three compartments after 10 minutes. And I think there are no doubts that there are extensive changes affecting the medial femorotibial joint. There are very large periarticular osteophytes based on the proximal medial aspect of the tibia and the distal aspect of the femur, which extends all the way towards the caudal aspect of the joint. And there is no doubt this horse has osteoarthritis. Also, the median condylar eminence is a little bit pointy. However, sometimes it's not quite as easy, and we do find only very mild remodeling of the proximal medial aspect of the tibia, and then it's a bit more difficult to decide is that significant or not. However, we should remember that radiology highly underestimates the degree of changes in the big joints such as stifle. So if we do see a small osteophyte, it doesn't mean that the joint is almost normal, because that osteophyte might be going all the way around the joint, actually be much more extensive than what we can see. Another thing to remember is that there is an association between osteoarthritis and presence of meniscal lesion on the medial meniscal lesion, and therefore ultrasound is recommended to evaluate the meniscus because that can affect prognosis. I'm not going to talk very much about chondrosis, but osteochondrosis affects most commonly the lateral trochanteric ridge of the femur. And actually, if you look at this case, we can also see very extensive soft tissue swelling associated with the stifle. Stifle swelling is not quite as easy to see as in the tarsus. So if you have only mild swelling, I think it's very easily missed, and you're better evaluated clinically. In this case, can be also seen radiographically. Changes of the lateral trochanteric ridge should be evaluated also in the oblique views, because that usually gives you the full extent of the lesion more than what you can see on the lateral medial view. What also interesting to know is that if you do radiographs of very young horses, weaklings, 6 months of age, they often have osteochondrosis at the lateral trochanteric ridge, but most of the lesion will disappear by the time of 18 months. And this is another study that looks at the same thing, so progression of lesions from 6 months to 18 months of age, but looking at thoroughbreds only. And again, lesion of the lateral trochanteric ridge, they are present at 6 months, and then most of them resolve by 12 months, and about 90% of them resolved by 18 months, and only very few, 6 in total, develop after the 6 months. Another common finding in the stifle is the presence of osteocystic lesion in the medial femoral condyle. We can see cystic lesion at the location. The proximal tibia is one of them, but this is really uncommon. We still don't know exactly what caused osteocystic lesion, and that is because probably it's multifactorial. Some horses, some cases are related to osteochondrosis and they are developmental in origin, but some are definitely traumatic, and we see those in older horses that had radiographs obtained when they were younger, had no changes at all, and therefore those cysts must have developed after they start the ridden exercise. And cysts in the medial femoral condyle have been reproduced experimentally with an artificially produced lesion into the articular cartilage and subchondral bone, allowing joint fluid to enter the deep subchondral bone, and cysts were created this way. There is a report of a few cases where there was a concurrent development of medial meniscal lesion and subchondral bone cysts within the medial femoral condyle. This is not a common occurrence, but it can occur, and therefore it's quite important to at least ultrasound the meniscal, the medial meniscus to check if there are lesions, because these horses that had a lesion of both, lesions had poorer prognosis than horses that had cyst on their own. While there is no doubt in interpretation of the cyst itself, sometimes we see flattening of the distal aspect of the medial trochanteric ridge, of very shallow depression, and those are a bit more problematic for me to interpret. These can be seen as incidental findings. If you have a mature horse that has been competing all its life and is sound, and you see a very shallow or just a flattening of the medial femoral condyle, well, that can be considered incidental. But in some cases, when you have a young horse, then it might be more difficult to know how those shallow lucency progress. And I found this paper, it was just been published in Equine Veterinary Journal, which looked at exactly this thing. So how shallow lucency, so lucency that are less than 3 millimeters in depth, progress with time. And they looked at thoroughbreds racehorses, and they looked at them as a wheeling and then as yearling. And they also evaluate the width of the articular surface that was involved, because they thought that perhaps it's not the depth that influenced very much how those lesions progress, but maybe the width is more important, and actually that's what they found. So the majority of the lesion, which are group 2, stayed exactly the same. Some lesion resolved radiographically, some lesion, especially the one that were larger, decreased in larger at the articular surface, decreased in size, and some lesion, only a few lesion progressed to become deeper than 3 millimeters and therefore defined as cyst. What was also interesting is that how does lucency influence these horses in their future career? And the only significant discipline they found was that they had a significantly less number of starts at 2 years old, but actually they had the same number of starts at the other horses without lucency at 3, 4, or 5 years old. And then the winnings was different, but it was not a significant difference between horses that had normal femoral condyle lucency or a cyst. Just a few example of fractures. Fracture of the patella are seen as traumatic. All the fracture in the stifle, most of the fracture in the stifle are traumatic in origin. Say fracture of the patella are often seen in event horses, and this example was actually an event horse, and that's because they tend to hit fixed fences. This horse had 2 sites of fracture. He had an extra-articular portion of the fracture, and you can sort of see in this location a fragment which may be articular. That one becomes very important to acquire the skyline of the patella to highlight the articular component of the fractures. And because it's in the medial pole, that's why it's very important also to tilt the stifle so that it faces outwards, and you have more chance to evaluate these regions. We can have a fracture of the tibial tuberosity, which are also traumatic in origin. These are usually non-articular, so sometimes it's very difficult to tell radiologically exactly where the joint finish. Relatively recently have been described fracture of the medial intercondylar eminence. I did actually see one of those many years ago, but I don't have the images anymore, and I really didn't know very much about it at the time. And these are also traumatic in origin. It was initially thought that these were avulsion fracture of the cranial cruciate ligament, but actually the cranial cruciate ligament does not insert on the eminence, inserts cranial to it. So this, that is not the case anymore. However, in many horses with this fracture, there are soft tissue changes present because of the closeness of the structures. So the cranial cruciate ligament and the cranial ligaments of the meniscus could be potentially affected. A little bit about soft tissue injuries. Radiography has obvious limitation to evaluate soft tissue injury in the stifle, and if we really think that the horse has changes other than in the meniscus, say in the cruciate ligament, for example, then perhaps thinking about CT or CT arteriogram. If you can't do an MRI, it's a good idea. If you go into Butler, you will find all the soft tissue attachments that are in the stifle. I do find these image is quite confusing, but there is this new paper. It's actually, I think, is much more easy to read and to use as a reference, and that's because they just take one ligament at a time and they X-ray it, and it's easy to see in which views you can best see each ligament attachment. And in this picture, which I copied from the paper, this we have the origin and insertion of the cranial cruciate ligament, and then in this one we have the origin and insertion of the caudal cruciate ligament, and this is the Caudomedial-craniolateral oblique, and which is described as the best view to evaluate the origin of the cranial cruciate ligament. So if you do suspect lesion dislocation, that is a reason why we can acquire this view. And this was also presented in this case report, where they had 2 horses that had avulsion at the origin of the cranial cruciate ligament, and they presented this Caudomedial-craniolateral oblique view as the best view to highlight this lesion. The cranial cruciate ligament insertion can also be evaluated radiographically. This horse had very chronic changes with severe cystic lucencies in the area of the attachment, and we can also see extensive enthesiopathy and remodeling of the tibial eminence. This horse also had osteoarthritis of the medial femoral tibial joint, and I don't have the ultrasound of this horse, but likely had other lesion of the meniscus as well. This is the last case I have for you. This is a 12-year-old warmblood which has a chronic moderate right hind limb lameness. It had mild effusion of medial femoral tibial joint. I don't think I will be able to see that radiologically. As I said before, mild swelling, it's very difficult to see, especially on the medial and lateral femoral tibial joint is just not visible radiologically in horses. But what I could see in this horse is that there's a mineralization or mineral opacity just cranial to the tibial eminence. I can see that only on the lateral medial view. Believe me, in none of the other views that we acquired that could be seen. In the caudal cranial view, there is evidence of periarticular osteophyte formation of the tibia and medial femoral condyle and remodeling of the medial eminence. But even if I don't see this in any other view, my best option for these sort of fragments is a lesion within the meniscus. So I went to ultrasound this horse, and this is the image of the medial meniscus from the medial aspect. And then as you proceed cranially, you could see the fragment and the lesion extended into the cranial meniscotibial ligament. And I think the reason why we didn't see this in the caudal cranial view is just because it was superimposed over the tibia and therefore not visible, but it was definitely within the meniscus on the ultrasound. So as take-home message, I think if you pay attention to acquire the best quality images that you can, then that will help massively in reach the correct diagnosis and help in the interpretation. We should also be aware that of the clinical significance of the radiographic findings and how those correlate with the clinical examination, and that not all lesions that we see are related to lameness, but also that a normal radiographs does not preclude the presence of significant pathology. And now we do have the possibility of doing CT and in some cases MRI of the stifle. We can certainly do CT and MRI of the tarsus, and therefore if we don't find the answer with radiography and ultrasound, then thinking about advanced imaging modality is important. And I have concluded. I have gone 1 minute over, so I thought it was pretty good. And if you have any question, please you can type them in the chat box, or you can even mute yourself and ask the question directly. Hope you enjoyed. I have gone a bit fast, but I was really aware that my presentation was far too long than the time I had allocated. Can you put the slides which paper of the TARSUS soft tissue attachment? Of course, I can try. Let me see. TARSUS soft tissue attachment is right. There you are. And American Journal of Veterinary Research, 2020. You can see this lecture again. These are recorded, so I believe you're going to receive a link, and then you can re-listen to it. So then you can slow me down and and find all the references. If you don't have any question, I'm gonna conclude, and thank you all very much for coming. Of course, if you have questions in the future, please do contact us, and hopefully we'll be able to help you. And I believe you will receive a link for the next and last webinar of the series anytime soon. Thank you very much for coming, and have a good rest of the afternoon or day, depending where you are in the world.